morning, everyone. I'd like to welcome you to the Canada Fetal Alcohol Spectrum Disorder Research Network webinar on mental health, suicidality, and FASD research and intervention strategies. This is the first part of a two-part series. We're just going to wait a few minutes while we allow people to join the webinar. So while we wait, please feel free to put into the chat where you're from and the respective territory that you live in. I live in the traditional territory of the Stalo people, the Sumas and Matsui Nation, and I'm very, very pleased to be able to live, love, learn, and laugh on these beautiful territories that they've taken such good care of. While we wait for people to come in, I just want to emphasize that this is not an easy subject area, that it can sometimes trigger thoughts and emotions, and it's important to take the time to reach out to people that can support you if you're feeling triggered by any of the content in the sessions today. The second part of the session is going to be in October, and we look forward to you joining for that session as well. I'm going to start now just by introducing myself. My name is Dorothy Reid. I'm the chairperson of the Family Advisory Committee for CanFASD Research Network, and part of the role of the advisory committee is to help to influence the research so it's practical and applicable to people who need the information: caregivers, individuals with FASD, service providers, policymakers, as well as researchers, and to be able to assist in knowledge translation, so to get the information into the hands of the people that need it most. And that's one of the reasons why I'm really pleased to be able to host this session today. I think it's an important area. An important part of what we do with CanFASD is to acknowledge the traditional treaty lands and recognize the people of the territories. CanFASD Research Network recognizes the historical significance and contribution of Indigenous people and their cultures, and understands the important role that Indigenous communities play today and in the future. We acknowledge that we live, work, and meet on traditional territories across Canada. Many of the First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. I just wanted to say a few housekeeping rules before we get going. We will be recording this presentation, and it will be available on the CanFASD YouTube channel. The Zoom function for this webinar has a question and answer function where you can ask questions, and if somebody else has already asked the question that you're interested in, you can upvote that question so that the most commonly asked questions will rise to the top. We're planning to have about 10 minutes at the end of the presentation for the speakers to answer any questions that are put forth. Now I'm going to introduce the presenters. Dr. Kelly Harding is the Director of Research Administration and a Research Associate with the CanFASD Research Network. He's also an adjunct faculty member in the Department of Psychology at Laurentian University. Kelly has a background in human development, interdisciplinary health, and health service delivery, particularly in rural and northern communities. She's worked in the field of FASD since 2010 and has been involved in diverse research projects in the area of FASD prevention, women's health, FASD assessment and diagnosis, family well-being, mental health, and human rights. Next, we have Dr. Dorothy Badry, who's a professor and researcher in the Faculty of Social Work, University of Calgary. Her primary research interests focus on FASD, child welfare issues, disability, women's health, and FASD prevention, advancing knowledge through education on FASD, issues of loss and grief, and FASD and suicide prevention. Dorothy is the Child Welfare Research Lead for Canada FASD Research Network and a lead member of the Prairie Child Welfare Consortium. She's the co-editor of the Youth in Care Chronicles, published in November 2020, that includes several young adults living with FASD. And she's received the Canadian Association of Social Workers Distinguished Service Award in 2021. Finally, we have Stephanie Howe, who's a doctoral student in the School of Applied Child Psychology program at the University of Calgary. She's previously completed her BA honors in psychology and her MSc in School and Applied Child Psychology at the University of Calgary. Stephanie's main research interest is related to children and adolescents with neurodevelopmental disabilities, for example, autism, intellectual disabilities, and fetal alcohol spectrum disorder, and co-occurring mental health concerns, such as anxiety, depression, and suicidality. Now, I'm going to pass it over to our presenters. Don't forget to put any of the questions you have into the question and answer option. Thank you.
Thanks very much, Dorothy. Welcome, everyone. It's wonderful to be here with all of you today on Friday. As Dorothy mentioned in her introduction, this presentation does deal with sensitive topics. And so we do flag for anyone that if you're feeling distressed by any of the content or you need to step away and take a break for a moment, that's totally okay. And please reach out to someone that you trust if you do need support, or reach out to us if you have any questions or you want to talk through any of the information we present today. But so this is part of a two-part presentation series, and so we are going to focus quite a bit on suicidality today, but we also hope that it translates in the context of talking about mental health, mental wellness, and mental well-being. And so really trying to think about it from a holistic standpoint as well, and certainly suicidality being a very intense outcome of mental health concerns, but also from a positive and strength-based perspective about how we might best support individuals with FASD and work in suicide prevention. So with that, I also just would like to acknowledge where all of us as speakers are calling in from today. So I myself am in Robinson Huron Treaty Territory. I'm in Sudbury, Ontario, which is the traditional territory of the Atikameksheng Anishinaabe people, and also home to the Wanapitei First Nation. And so Dorothy, would you like to introduce the traditional lands from Calgary, where you're calling in? Dorothy Badry?
Yes, I'm here. Sorry about that. Unmuted. I'm from Treaty 7 territory in southern Alberta, which includes the Blackfoot Confederacy, as well as the Tsuut'ina First Nation and Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta in Region 3, but I'm presently in the Kootenay region, the traditional and unceded territory of the Tanaxa, the Kinbasket, Syilx, and Sinixt peoples. Thank you.
Thank you, Dorothy. And so I would also like to acknowledge our research team before we get going with this presentation today. So Dorothy, Steph, and I are all researchers on this project, but we have worked as part of a very large and diverse team that has contributed to multiple parts of this project and some of the findings that we're going to acknowledge today. And so I do want to just pay tribute to our colleagues, Dr. Carly McMorris, who was another co-principal investigator on this project. She is also at the University of Calgary, as well as Amanda Awasiak, who was our community partner at CASA. And then we have a number of team members who have been involved as well, that represent diverse organizations, backgrounds, experience, individuals with lived experience. And so very grateful for their contributions to this project as well. So even though we are presenting on the findings, it's really representative of a large team effort on this work. So I'm just going to talk a little bit about what led us to this work and a little bit of context setting before I pass things over to my colleagues. So this really came about in around 2017 or so, 2018 or so, before the pandemic, around youth suicide prevention, specifically in Alberta. And so Alberta released its youth suicide intervention strategy in 2019, and tied to that strategy was a call for funding opportunities looking at youth suicide prevention. And so we saw this grant, got interested in it, have been talking for quite some time about the experiences of suicide for individuals with FASD, which is still a relatively under-researched area, but at the time, certainly there was not a lot of literature on this, but knowing that, you know, upwards of 90% of individuals with FASD experience mental health concerns. And so we kind of flagged that this would be a good opportunity for us to do something in this area and to increase the knowledge base. So we submitted for that grant, were successful, and that was kind of the impetus for getting going with this work. And so knowing that FASD and suicidality is an increasing concern among individuals with FASD, wanting to understand what that looks like, what are the opportunities for intervention and support, and really, you know, what's the prevalence, like even some of these basic questions of wanting to understand what's happening for individuals with FASD. So what we did know, or what we do know about suicidality among individuals with FASD is, of course, that it's complex and involves many intersecting biopsychosocial concerns. And so we know that the complexity of these concerns can exacerbate vulnerability for individuals with FASD, for mental health concerns, and for suicidality. And because we know that individuals experience these significant mental health concerns, really wanting to understand what suicidality looks like in this population. And so when I use the term suicidality, I'm referring to the spectrum of suicide-related concerns. So that may include ideation, so thoughts about suicide. It may include actual attempts, and may include death by suicide. So we're not going to talk about all of these pieces today, but as I mentioned, it was a relatively large and diverse project that did have multiple components. And so our first piece was a scoping review that looked at what is known in the literature about suicidality among individuals with FASD and their families. We also did an analysis of the National FASD database around suicidality, the prevalence of suicidality among the sample of individuals in the database, and some of the intersecting concerns that might be predictive of suicide-related behaviors. And then the part that I always get the most excited about, the qualitative research component, we did interviews and focus groups with a large, diverse population of people kind of in this space. So that included researchers, clinicians and other experts that work in the field and support mental health for individuals with FASD, individuals with FASD themselves, caregivers, and frontline service providers. And so some of you on this call today may have heard us present on various components of this study up till now, but today we really wanted to focus on the qualitative and sort of lived experience components of this work and present some new findings from this piece, and so that will be our emphasis today. And one thing I'd like for you to keep in mind as we go through this presentation is this framework. So this is the social ecological model. I'm sure many of you have come across this in different capacities in your work and in your research. But really thinking about these different levels and how they intersect. So thinking about individual level factors, relational and familial level factors, community and societal. And so we will come back to this as we go through our findings and talk and present some of the quotes and so on. But really also thinking about how each of these are not individualistic, how they interact together, and how that influences the complexity when it comes to talking about FASD and suicidality. So with that, at this point, I will pass it over to Steph, who's going to present the first components of our results. Then I will come back in to talk a little bit about some of the caregiver stuff. And then Dorothy's going to talk about the service provider and professional experiences. So you'll hear all of us kind of jump back and forth a bit and present, but Steph, over to you.
Great. Thank you, Kelly. So as Kelly mentioned, the project involved conducting qualitative interviews and focus groups with different groups of people, all with the purpose of better understanding the experiences of suicidality among people with FASD. So we spoke to 14 professionals, including researchers, clinicians, and frontline service providers, and 5 caregivers of children and youth with FASD, and then 4 adults with FASD themselves. And we also had caregivers across Canada complete a brief online survey. So 23 caregivers responded about their children's experience of suicidality. Children had either caregiver reported prenatal alcohol exposure or a formal FASD diagnosis, and they were 8 to 26 years old and 70% identified as female. So while previous research tells us that suicide is very, very common in children and youth with FASD, before this project, nothing was really known about what that looks like. So as Kelly was talking about, as a spectrum of suicidality, looking at frequency, intensity, duration of suicidal thoughts and behaviors. And then these gaps in our knowledge about the experience really impact our ability to meaningfully respond and intervene. So the survey responses offered crucial insight into the experience of suicidality, as well as contextual factors that might be related. Almost 1/3 of the sample reported visiting the emergency room because of mental health concerns, and this was most often because of suicidality. And then 82.6% of the sample had at some point endorsed thoughts of wanting to be dead. And caregivers in the study really highlighted the severity and persistence of these thoughts. Many caregivers said that their child's thoughts of suicide happened almost every day and they lasted an hour or more, and that most really had difficulty controlling their thoughts. And 21.7% had ever made a suicide attempt. And of participants who had attempted suicide in the past, the number of attempts ranged from 5 to 20 attempts. And then 65.2% had engaged in non-suicidal self-harm. And almost all of those that engaged in non-suicidal self-harm also experienced suicidality. So they often go hand in hand. And caregivers that completed the survey had the opportunity to tell us more about their experiences in open text boxes. And many wrote about what was going on for their child when they were feeling suicidal and what events or experiences may have contributed to their suicidality. So we analyzed these open-ended responses and we identified 3 major contexts or reasons for suicidality. And the first and the most common was reactive responding. So many caregivers talked about suicidal ideation of their child or youth as being in reaction to things like conflict, frustration, or stress. For example, one caregiver described her son's suicidal comments, explaining that he doesn't really understand the practical meaning of it. He uses phrases like this when he doesn't like what's going on, but he just wants it to go away and or stop. And several caregivers also reported that their youth's suicidal thoughts occurred in reaction to things that they regretted. So she often just wants to die when she makes a poor choice. So people with FASD might encounter challenges, stressors, or unmet needs and see suicide as an escape from their current situation. But many caregivers also felt that their child wasn't really able to understand the potential consequences of suicidal behavior or the finality of suicide, which I think we'll talk about more later. And then the second context is shame or not fitting in. This was often related to social isolation, exclusion, and marginalization related to having FASD. So one caregiver described this experience for her daughter, noting that when she is overwhelmed with feelings of sadness, that she is not what she considers to be normal, that she has thoughts of ending her life. Another caregiver discussed her daughter's suicidal ideation and explained that having FASD made her feel less worthy than people that don't have this disability. She figured she was just using up space and might as well not be here. And then the last one is a general sense of hopelessness surrounding the experience of suicidality, as well as a desire to numb experiences of pain. So one caregiver noted that her daughter has often said she just wants to fall asleep and never wake up. And another caregiver noted that her son talks about wishing he was dead so he doesn't have to deal with all the problems he faces daily. So this theme is more related to the depression that we usually see in the general population. And then I'm going to pass it over to Kelly to talk more about the interviews.
Thanks, Steph. So as Steph was presenting there, we conducted the survey first, and then from conducting the survey, recruited our caregiver participants for more in-depth qualitative interviews. And so what we heard from them in the interviews really elaborated on and expanded on some of those preliminary themes of, from the caregiver perspective, what was contributing to experiences of suicidality among their children and youth. And so for our caregiver piece, which is published and available open access, if you're interested in giving it a read, we actually combined all of the experiences that we heard from caregivers and wrote it up as a vignette. So essentially as a narrative story that weaved together a lot of the quotes and experiences from all of our participants to create one sort of overall combined story. And so for that reason, I'm not going to present individual quotes, but I'm going to talk a bit more broadly about what we heard from caregivers in the interviews in the context of suicidality. And so coming back to that social ecological model, we really constructed our findings around the different levels of this framework and what the experiences are at each of these levels. And so within the individual level of factors, these are some of the concerns or considerations specific to the individual with FASD. So things like their socio-demographic characteristics, their other experiences of mental health or co-occurring conditions and physical health conditions, experiences of substance use, so alcohol, but other drugs as well, early life trauma, which was talked really quite a bit by caregivers, and familial conflict. And so a lot of this centered around experiences for their youth who were adopted and still had connection to their biological families. And so in a lot of cases, this was a really big strength for families, that it enhanced their connection to their families and their culture. But then in other places, actually talking about that involvement with the biological family, in particular siblings, could be really re-traumatizing. And so parents would talk about the experience of when their youth went to visit with their family and came back. And actually that was quite a big source of tension, had caused some experiences or feelings of suicidality, of feeling of not belonging. And so sort of these really intense emotional responses that perhaps were quite challenging for the youth to deal with from the perspective of their caregivers. And so when this kind of expands out into the relational level, you can kind of, I hope, see what I mean here about how these intersect. And so it might be at the individual level of responding to those situations, but certainly that intersects with the relational factors of connection and community and wanting to belong and wanting to find supportive and positive relationships. And so caregivers talked quite a bit about feelings of belonging, or more so lack of belonging, especially with peers and particularly in the context of school. And so that these were experiences of not feeling engaged at school, perhaps even going to the point of bullying or being picked on by other peers, and really not having strong friendships. And so to the point that going to school was a trigger that led to suicidal thoughts and behaviors. But I also want to talk a little bit about the strengths and the positives here as well. And so the influence of peer groups is kind of one of these things that can go both ways. And so certainly there were experiences of poor peer groups or negative peer groups and bullying, but some families also talked a lot about how positive some of the relationships and friendships that their children and youth had. So having a really good best friend who they had known their whole lives, who was someone who really their child or youth could rely on, and that people at school would defend them and stick up for them on their behalf. And those were really positive experiences that led to good mental health and well-being. But caregivers worried about what happens as their youth gets older, or as peers start having relationships with other people, or making new friends, or graduating high school and transitioning out, that there was a fear of what will happen if their youth loses that friendship or that source of support, and what that might mean for their child. And here is also the consideration around suicide being an issue that affects everyone, that affects all people. And so it is the youth who's experiencing the suicidality, but that has a significant impact on the whole family unit, on caregivers, on extended family members, on siblings. And so in some cases, talking about how that had led to significant experiences of stress or concern for caregivers, of feeling like they had to constantly monitor the home setting, keeping an eye on their child, ensuring that they had a safety plan in place, and the tremendous amount of work and mental load that can be for caregivers to ensure the safety of their youth, especially if they felt like other places like schools were not doing a good job of keeping their youth safe, and feeling like there weren't other people who were also, in their camp or on their side, supporting them and keeping their youth safe. And then as we continue to expand out in the ecological model, we get to more of the macro level and systemic level considerations that intersect with suicidality. And so at the community level, caregivers talked quite a bit about the potential consequences of late or non-existent access to mental health services and supports. So in some cases, depending on where you lived, if you were in a rural community, perhaps not having any mental health services that you felt were helpful or were FASD informed to support your child or youth. And related to that, having good interactions with service providers and access to networks to feel supported and connected. And so this varied for families, but I think also parallels what we heard from the survey responses about perhaps not feeling like there's somewhere to go if you're in a crisis situation and need help. And sometimes the emergency room seems like the best place or the best solution if you need instant support and intervention. But some caregivers actually being very apprehensive because of perhaps their own experiences of trauma with the medical system or healthcare providers, and really being very hesitant and very reluctant to go to the emergency room for support. And so this leaves families in a very precarious place of knowing they need help and support, but still feeling like that's not available to them or easily accessible. But an important part to highlight here too is also, as we've heard in a number of different caregiver studies, around access to informal support networks. And this could be things like other parents of children and youth with FASD, other parents and youth of children with other neurodivergent conditions, or even just like really good friends in the community or people that they have in their own corner. And so knowing who those people are to reach out to when you need more informal sources of support, even if more formal support perhaps isn't available. And then lastly, at the societal level, this is where we focused on some of the really big picture challenges and systemic concerns. And so things like stigma, persisting stigma against, alcohol use during pregnancy, FASD as a disability, and how that intersects with how we approach people, how we understand people, how we communicate with people. Other issues like racism and discrimination, so particularly for individuals who identified as being part of multiple marginalized groups, both visible and invisible, geographic location, so things like rurality, and so on. And then the impacts of COVID-19. So this study was not originally designed to be about COVID, but it just happened to coincide with when we were collecting our interviews for this project. And so we conducted our interviews in 2020 and 2021. And so families talked quite a bit about the impact of COVID on their youth. And so even further limiting any support or peer intervention that they had, loss of services or community groups that they attended. One family talked quite a bit about how their youth was a really good swimmer and loved to go to the public school and swim. And that was an excellent outlet for their challenges and a great diversion. But because of closures from COVID, they couldn't go swimming. And so that had a substantial impact on their mental health. And so that was also an important consideration that kind of came about within our project as well, about the experiences that families were going through in lockdowns and other experiences related to COVID. And so again, thinking about the interactive component of the social ecological model, one thing that I just kind of want to flag here is how complex this is, especially when you are thinking about multiple marginalized identities. So we often center in our work the experience of being disabled, and I use that term intentionally. And so considering FASD as a disability, but many of the families that we talked about membership of other marginalized groups. So if that was someone who had a diverse sexual orientation or gender expression, whether or not that individual identified as neurodiverse or neurodivergent, and how those other identities that are also politicized may also experience your own discrimination for, also intersected with having an identity as a person with FASD. And so when we think about it in the larger context of stigma and discrimination, of perhaps being discriminated against because of any number of those identities, that it really heightened the complexity, the mental health concerns, the experiences of suicidality for individuals with FASD and their families. And so that's the caregiver perspective, but I also do want to call attention to the experiences of individuals with FASD themselves. And so we conducted a focus group with individuals with FASD who shared about their own lived experiences of having FASD and experiencing suicidality. And so we presented this quote in a few different contexts, but I think it's one of the most powerful ones that lingers from this project. And so as a person with FASD said, a lot of people don't want to die, they just don't want to live. And so this really, to me, highlights how much we need to ensure that individuals with FASD feel connected, feel a sense of belonging, feel a sense of purpose in their lives and in their communities, of wanting to give back, of wanting to be included. And so it's not actually that they don't want to be here anymore, it's just that sometimes living is so hard when they feel disconnected, when they don't feel supported, when they don't feel understood. And that challenge of fighting to exist and to be included can be very overwhelming and can be a lot. And lastly, when we're thinking about those intersectional considerations as well and thinking about the macro, individuals with FASD also talked about language. And so again, coming back to stigma and how persistent stigma is and how powerful stigma can be in generating these kinds of concerns and outcomes, is that there's a lot of power in language. As soon as you see the letters FASD, the thing that pops into my mind is everything I'm not going to be able to do. And so this is also calling out how for so long we have been entrenched in a deficit-based narrative of FASD, that even sometimes the language of saying FASD conjures a very specific thought in people's minds about what people can and can't do. And so even for this individual, framing it as everything I'm not going to be able to do, rather than what are the things that I'm good at? What are the things that I can do and can do well? And so it's also shifting this way that we talk about and think about FASD, and to, again, coming back to a more strength-based approach to think about how individuals with FASD can be included and how we can leverage strengths. So with that, I would also like to pass things over to Dorothy, who's going to talk about what we heard from service providers and frontline professionals.
Thank you very much, Kelly, and thank you, Dorothy Reid, for starting us off, and Stephanie. And we just want to acknowledge that September 9th was International FASD Day, and September 9th was World Suicide Prevention Day. Interesting that those two are so aligned, especially with us doing this presentation today. People who have been diagnosed with FASD, it's not going away. They have FASD and will for life. You're really just trying to mitigate the adverse outcomes. So that is the voice of a professional. So one thing that we did, and Kelly really did a nice job of contextualizing the research that we did. And, when the call for research came out, Audrey McFarlane actually brought it to our attention. And one of the things that we did in our application very intentionally was to focus on FASD and say this is, one of the most high-risk populations for suicide that we know about anecdotally. And there had been very little information published really since about 2008. And so, I look back and, really credit the work of Janet Huggins and others who have really tried to take up the issue of FASD and suicide. But, we knew that it was time for new work on this area. So these are the voices of the professionals who participated in our focus groups that we're presenting actually for the first time in this kind of presentation. I'll go to the next slide. So when we talked to professionals, they came together and they had a lot to say because they work across a variety of systems, and we have a variety of professionals, you know, from fields such as psychology, social work, the disability sector, and a lot of people doing frontline work through, particularly in Alberta, through our FASD service networks. So one professional said, youth that have been in and out of the system or in and out of foster care don't trust people. So who are they going to tell if they're scared, or if they're not feeling okay, or if they want to commit suicide, or they want to cut? And we did hear a lot about self-harming behaviors, and Stephanie talked about that as well, that is a genuine risk. And you know, the point that Kelly made about people who don't want to die, but they don't want to live, is really an important reflection of the pain, that the personal pain that the individual is experiencing. So they don't have the trust in anybody to be able to walk up to somebody and say, hey, listen, I'm not okay right now, I need help. They don't have the capacity to be able to do that if they don't trust somebody. So one of our really important messages from that discussion in particular is that we must really support our children and youth in care who are living in the system, and really need to have those trusted relationships with individuals that they can reach out to, because they are a highly vulnerable population in terms of these risks for mental health challenges that can contribute to suicidality. Next slide. Risk was another theme that really stood out from some of the professionals. And, you know, one youth said, I don't want to feel it when I go, but I don't want to be here anymore. I don't want to live this life. Why didn't they love me? Why didn't they want me? And we're clearly aware that this is a young person who is in care, who's experienced rejection, who is also grieving the loss of their family, their own family, their biological family, and really needs a lot of support in terms of working through these issues. They, the youth, are so stuck in these whys that they can't move forward with their life. So they feel like it's just easier to end it than to continue to feel this way day in and day out. Stephanie certainly referred to that sense of depression and the mental health concerns that come with that. And we do see in the youth that are experiencing suicidality that they are really struggling with their mental health. You know, one thing we know is that caregivers and families, as Kelly talked about, really walk that journey with the families, and they're the ones that provide the quality of life. So one professional said, quality of life, I believe, plays a part of that, and just feeling very alone in the world and confused because they're already struggling to make sense of the world. So anything we can do to support young people to make sense of the world that they're living in is really important. We need to, that built environment around that young person is extremely important. And we need to look at that built environment and think, what are the elements that are going to make that most successful for that individual? We have clients who have zero suicide ideation, no self-harm, nothing. Then one day they become emotionally dysregulated and they go, I'm going to kill myself. Now that's a pattern of behavior, and with stuck behavior, they go on that and they don't let it go. So it's really important to recognize that a youth who has not expressed suicidal ideation can suddenly one day just express it. And we really do have to apply safety considerations for that individual, because we really do recognize how much at risk they are. Okay. So in the professional experience, we know that youth with FASD face multiple challenges. And professionals tell us that these are the youth that are most difficult to place, that nobody wants to take them. They have trauma and difficulties in day-to-day life. And the emotional dysregulation that comes with FASD also contributes to suicidal ideation. It's really important to think about, if you have a youth with mental health challenges, who's experiencing depression, who's going through loss and grief in relation to some of the issues as to why they're involved in the child welfare system, it's really important to recognize that emotional dysregulation needs to be supported, and we need to find strategies and effective ways to help that young person cope with day-to-day life. And as Kelly talked about earlier, you know, sometimes they have a good friend. Like, I like to think about, you know, people on the inside in the various environments in which a child is, to kind of sometimes tap that person on the shoulder and say, can you support this individual? I don't think there's anything wrong with that, especially when there's a youth that's really struggling. I believe that there are times that you just have to ride out that wave of behavior and kind of bubble wrap them and keeping everything safe around them until they become emotionally regulated again. And sometimes that bubble wrap is taking the young person to the emergency department. Sometimes it is distracting them. I remember one of our professionals saying, you know, they had an individual who was expressing suicidal ideation, but they distracted them and said, let's go do this today. And it actually worked. So, you know, it just kept that person safe for the day. It doesn't mean it didn't happen the next day, but it kept that person safe for a day. Okay, next slide. One professional said, I'm not entirely sure that the concept of suicide is grasped in FASD. That is what we at the home have always tried to wonder. Do they even know what that means? And is the concept of death too big? Do they really know what dying means? I'm not here anymore. What does that mean? Because understanding you won't exist anymore is a huge concept. And so, you know, when you really think about what we heard from people and think about the challenge of what it means when a young person says, I want to die, I don't want to be here anymore, especially a vulnerable young person with a disability, namely FASD. Do they really understand the implications of what that means? And, you know, one of the things we learned in, you know, hearing about the stories and narratives of the youth was that a lot of youth engaged in self-harming behavior, but it wasn't self-harming behavior that would actually lead to their death. But we also recognize that there is a lot of impulsivity with FASD, and that the risk of suicide needs to be taken seriously, needs to be assessed, needs to be evaluated, and needs to be acted upon, because we don't know what that individual is going to do. And so it is really important that we really pay attention to those concerns, because we know there's underlying mental health concerns. We know there's often underlying depression. We know there's often issues of loss and grief that young person has experienced their whole life. And so we really need to provide those kind of supports in that moment when we know those things are happening for that young person. Okay. So one of the things that came to us as we were doing this work was recognizing that there's gaps in service provision. And one of the things that came across loud and clear from professionals was a lack of FASD informal supports in responding to mental health concerns. How many professionals working out in the field have had FASD training? How many professionals understand the complexity of the mental health challenges and other challenges, health challenges associated with FASD? It's really important to think about that those that are intervening have some knowledge about FASD, and it often is up to caregivers who are taking children into emergency room, or youth group home staff, or other caregivers, even child welfare workers, to educate those around them about the unique needs of this child, especially when they're experiencing mental health concerns and attending at the hospital, for example, due to suicide risk. There are lengthy wait lists for specialists. And some individuals talked about having to wait up to 2 years to see a psychiatrist for their youth. There's serious substance abuse. And one of the things that we were pretty surprised at was how early the substance use started, as early as age 9. In Alberta, the Protection of Children Abusing Drugs Act, or PCHAD, can be utilized to provide a secure facility on a temporary basis, but youth require extensive follow-up support that are especially those who are engaged in drug use really early. And we know that substance use can clearly contribute to some of the risks around suicidality. Is this me, Kelly? Sorry.
Yes.
Okay, sorry, thanks. Just got lost for a sec there. So one of the things that we recognize is that there's intersecting voices. There's a crossover in the voices of in-body, in-home, and professional lived experience. So the individual, the caregiver, and the professional experience. There's these intersections that are occurring. Core messages that individuals with FASD, while at risk of suicidal thoughts and behaviors, are also at risk of the completion of suicide. And, you know, those situations where the individual's at risk of completion is often driven by a crisis and very clearly linked to historical trauma that the individual has experienced that really does remain unresolved and that they carry with them throughout their life, even their young life. A clear need to ensure a sense of community, belonging, and compassion exists. This is what we need to build and scaffold around that individual to support them in these experiences. Next steps.
Okay, I'm gonna take it over for next steps. Thank you so much, Dorothy and Kelly, for sharing that information about the focus groups and the interviews. It's very, very valuable information that gives us really good insight. Excuse me. But now the question is, now that we understand more about the experience of suicidality in people with FASD, we want to know more about what we can do about it. And so how can we identify people with FASD that are at high risk and prevent deaths by suicide? And one of the things that we can do is to identify effective and valid suicide screening measures for people with FASD. So this is a new project we're working on, and it's a grant funded by the Canadian Association for Suicide Prevention. And it has much of the same team as our previous project that we've covered today, including Dorothy and Kelly. And what we want to know is whether there are any tools like questionnaires, rating scales, interview questions, etc., that are appropriate and effective to screen for suicide risk in people with FASD. And this is once again a multi-part study with three main parts. The first is a systematic review of the literature to determine what measures are already out there, what's currently being used to assess for suicide among people with and without FASD. And then the second part will be a survey of professionals who work with people with FASD in a mental health capacity about how they might assess for suicide risk, any important considerations or adaptations that they make. And then the final part is individual interviews with people with FASD. And we want to ask about the experiences of interacting with healthcare professionals when they've been experiencing suicidal thoughts and what might be helpful and not so helpful. So I will talk a little bit more about the systematic review, which we have started over the summer a little bit more. And so there has been a very similar systematic review that's been done before. So Sarah Cassidy in the UK looked at screening tools used with autistic adults. And then myself and some others in my lab looked at screening tools used with autistic children and youth. And basically what they found is that there was nothing out there specifically for people with autism. They found some tools used in the general population, and they used one, the Suicide Behavior Questionnaire Revised, and they gave it to autistic adults and found that they interpreted the questions very differently, and that non-autistic adults, and that the tools that they use in the general population likely aren't accurate in capturing suicidality in people that are autistic. And I'm guessing that it will be similar with FASD. But what they did is that they adapted a tool used in the general population for autistic adults specifically called the SBQ-ASC, and they created that along autistic adults. So I think that is our major goal for this project, is to ultimately have something that we can use for people with FASD that accurately represents their experience of suicidality. So as for where we are with the systematic review, we've found 0 tools used to screen for suicidality in people with FASD. And we're currently looking at tools that they commonly use in the general population to see if any of them could be useful for people with FASD, or if we can adapt them or create a new tool from scratch specifically for people with FASD. And why tools created for people without FASD might not be helpful for people with FASD. There can be a lot of different reasons, such as communication difficulties, a lack of social connectedness, difficulties recognizing and describing emotions, difficulties in abstract future thinking. So I know that a lot of the questionnaires say things like, do you think that you will die by suicide in the future? And people are like, I don't know what's going to happen in the future. So it can be a really vague question and things like that that are difficult to answer, as well as challenges understanding the finality of death, difficulties in emotion regulation and impulsivity, as well as the context, which we've talked a lot about. There are a lot of intersecting factors, co-occurring conditions like other mental health conditions, and other things that need to be considered when assessing for suicidality. So we are currently at the point in this project where we are still planning things out, and we're looking for people with FASD or people close to people with FASD to help guide the project and share their experiences and share what we want to be asking people and how we should be asking it. So if you are interested in helping to guide and inform this project, please email enhancedlab@ucalgary.ca, and I'm sure that will be in the chat.
So research, policy, and practice implications of this research. What we recognize is clearly that more research is required on all aspects of suicidality. You know, there's so many gaps in strengths-based approaches with this population, and we need to know more about the protective factors that help prevent suicidality. There's a tremendous gap in longitudinal studies that explore trajectories of mental health and suicidality across the lifespan. And, you know, one of the things that we noted is that, you know, caregivers that were participating in our research had very young children to adults. So it was really helpful to get that broad horizon. And one of the things that we know is that the youth in particular and young adults are at very high risk. We need more detailed investigations of the spectrum of suicidality. We need to know more about anything that supports prevention and intervention, and if there's any studies with control groups. We need to also be able to effectively assess risk of suicidality among people with FASD. And as we know, and as Stephanie has told us, we have very limited tools to help us in that regard. One of the things I know that we really count on is the amazing work that is done by those working on the front line of FASD. There's a lot of experience, there's a lot of professional knowledge, and there's a lot of people who intervene on a day-to-day basis in supporting individuals with FASD that do incredible work in this field. And we need to know more about life experience perspectives and the identification of life-affirming programs and resiliency building programs that align with cultural principles of reducing suicidality. We need to do more work in the area of policy, and we need to do more area in practice. So one of the things that, just a quick highlight, I'm not going to read it all from policy, is that diagnosis should follow screening. So we always need access to diagnostic resources because that is the template for planning for individuals with FASD. And in terms of practice, we need to really be more knowledgeable about you know, how we screen for suicide, how we screen for mental health challenges, how we respond to crisis situations for individuals with FASD, and, you know, how we align all that with various interventions that would prevent suicide. The FASD field should develop parallel or modified training to help professionals in a variety of contexts and settings to screen and support those with FASD, particularly in the area of mental health challenges. So what are some of our recommendations? Early identification is really important, especially around the area of mental health and suicidality. And we really need to be aware of the context in which a young person might express suicidality and what is happening in that environment. And we need to think about the protective factors that would support us to support that individual in that environment. We need access to timely and well-suited supports to promote mental wellness and address mental health concerns such as suicidality. And timely is absolutely critical. When a young person is expressing suicidality who has FASD, we need to act right away. You need to get supports right away. We need a shared understanding of needs and strengths and the use of existing resources, because we do have to work with what's available to us in the current system. Broad stigma reducing initiatives across the lifespan for individuals with prenatal alcohol exposure and FASD. So the floor is open for questions. Thank you, everybody.
Thank you very much. I'm just going to take a moment now, because I know we're getting close to the hour and some people might need to leave. We will do some question and answers. However, I just want to give a big thank you to the presenters today. And it's been it's amazing how fast an hour goes when it's such an interesting topic. I'd like to thank each of you for joining the presentation today, and hope you'll join us for future webinars. Again, the second part of this is going to be in October, so keep posted. To get more information on CanFASD and to stay in the know with all respects to upcoming webinars, check out the website at www.canfasd.ca or follow us on the social media channels. And remember, again, to join us on October 13th for the second part. So again, if there's you know, if you had emotions come up throughout this presentation, please reach out to people who are a support for you. It's a difficult subject, but it's an important subject to talk about. So thanks to our presenters, and thanks to everyone for joining, and we'll see you on October 13th. Bye.